friends, once again, very good evening to you all to yet another session of Brendos. For those who are new to this program, Brendos is the Breast and Endocrine Society of Western Uttar Pradesh. It's a small effort made from our side. Myself, Dr. Sudhi A Kamboj, the breast and endocrine surgeon hailing from Western UP in Meerut, to provide an online academic forum on a monthly basis where we can discuss about breast and endocrine related disorders on an alternate basis. So we have a very structured program. We conduct breast meets on every even month and endocrine meets on every odd month, so that we have a holistic discussion about these. Meetings are very unique in the sense that these are problem based learning programs. So what we do, we pick a clinical problem from the patients that we see in our clinical practice, and we discuss about that case with the actual images of the patients, their radiology, pathology, nuclear medicine images, their surgical gross photographs, everything. We discuss about them with actual images with the help of the specialists who have actually reported those investigations, so that the others, those who listen to that case, they have an imprint in their mind that the reports that we read, how those reports are actually seen by the pathologist, what are the actual pathologies they see, visualize in their reports. Also, the pathologists, radiologists, nuclear medicine physicians, they also understand from the clinicians, from the surgeons, how their reports have affected the clinical management and the ultimate outcome of that patient. So, through this program, we try to collaborate all the specialities who have ever been involved in the management of that particular, those type of cases. And through this program, we provide an opportunity that each one of us can interact. Most of the time, it happens that we interact with the cases in our own specific forum. But in this forum, we have all the specialities on a single platform where we can discuss about the case and learn from each other. Okay, so friends, now July being an odd month, this time we have an endocrine meeting, and in this meeting we have a very interesting case of a papillary thyroid cancer. Friends, papillary thyroid cancer, those who deal with these papillary thyroid cancers, they know how important the management of these cancers has reason, because these are very uncommon cancer. As such, if we compare with the other cancers, however, they are the most common endocrine malignancies, and they exhibit very characteristic features. So their management is not something like we just remove and we just forget about it. Nothing like this. There is a very specific protocols, a multidisciplinary approach that we need to take care of, and specific protocols that we need to maintain or follow up to manage such cases. And through a very interesting case, we have taken the opportunity that we discuss about this problem today. In today's program, we have very eminent faculties with us. Dr. Arvindan Nair, sir, he was the head of. I just really want to introduce everyone about sir. He is one of the father figure of endocrine surgery in India. My teacher's teacher in, and he was a former head department of endocrine surgery. In fact, in his tenure only, the department of endocrine surgery started taking shape, and it separated from the department of general surgery and established itself as a separate department. And he was a former head of department of endocrine surgery. He's with us right now, and his feedback will certainly add to our knowledge. And I have with us our moderator, Dr. Santosh Singh. Dr. Santosh Singh, he graduated from his MLN Medical College from Allahabad, then did his MS from KGMU Lucknow, and he's a very hardworking and a very dedicated oncosurgeon who did his DNB in surgical oncology from Army Hospital RNR, New Delhi, and currently he's a practicing oncosurgeon, a very prominent oncosurgeon in Meerut. And I'm thankful to you, Santosh, that you consented for being a moderator for our session, and your feedback, your comments will add value to our session. And I request Dr. Santosh now to please take over the program and he will introduce our guest faculties to everyone. Also, he will make some announcements regarding this program. Thank you very much, Santosh. Over to you.
Thank you, ma'am, for your kind introduction and invitation. Good evening, everyone, and welcome to the Brendos monthly webinar series. And thank you, Dr. Sudhi, ma'am, for this great initiative of Breast and Endocrine Surgery webinar series. It's my pleasure to moderate this program wherein we will explore all the subtle aspects of papillary thyroid cancer management. As we all are aware that differentiated thyroid cancer, more specifically papillary thyroid cancer, makes approximately 80 to 90% of all thyroid malignancies, and by far the solitary thyroid nodule is the most common type of presentation. Today in this session, we will try to cover every detail of evaluation, investigations, treatment and follow-up protocols for the survivors of thyroid malignancy. We have very learned and revered guest faculties and panelists who will sail through the treatment journey of papillary thyroid cancer. Now, may I briefly introduce our guest faculties, Dr. P.V. Pradeep, presently a senior consultant endocrine surgery at Baby Memorial Hospital, Kazipode, Kerala. Sir is President-elect Indian Association of Endocrine Surgeons. He is editor and reviewer of several indexed medical journals, including Indian Journal of Endocrine Surgery, Indian Journal of Surgery, World Journal of Endocrine Surgery, International Surgery, and many more. He has authored 3 books and several book chapters and more than 80 publications on his own credit. Welcome, Dr. P.V. Pradeep, sir. Welcome. Our second guest faculty, as Sudhi ma'am has already introduced, Dr. Nair, sir. He is supposed to be the father figure of endocrine surgery. Welcome, sir. Our speakers today are Dr. Sudhi Agrawal. She is Senior Breast and Endocrine Surgeon at Nutima Hospital, Meerut. Dr. Chani Jain, a very learned and dynamic oncopathologist of Meerut. And we also have esteemed radiologists and nuclear medicine experts among us to enlighten very peculiar aspects of thyroid cancer management. Welcome to Dr. Meena Bembi, consultant radiologist at Krishnaraj Diagnostic Center, Meerut, and Dr. Reena Dhamija, senior consultant nuclear medicine from Meerut Scan Center, Meerut. To start with, I would like to make some announcement like while some speaker is speaking, please make your microphone in off mode. And if you are getting engaged to some other work, please turn off your camera mode and let the program go ahead. I would like to invite Dr. P.V. Pradeep sir to say a few words regarding this program, and then we will proceed further. Dr. P.V. Pradeep
Thank you,
sir.
Dr. Thank you, Dr. Santosh. Am I audible?
Yes, yes. Very well.
Okay, and at the outset, let me thank the Brendos for this opportunity to participate. I have heard that Sudhi is conducting this program for last several months, and unfortunately, because of the schedule here, not able to participate in those. And I think Sudhi has made sure that I participate, calling me as a expert in this. And I'm extremely happy to see Dr. Arvindan Nair sir here. So it's nice meeting you on this forum. And let us see how the discussion goes. I'll try to contribute whatever I can. And I can see that all the experts are already here who will contribute to the discussion. That's a great initiative, Because even now, when we go to PGI for the STPGI for the PG courses, we look forward to the endoradiology, endopathology sessions. It's so informative, and it's a sort of a revision for us. After passing out MCH in 2000, I think it was in 2008, yes. So long years. So you don't get time to revise all these things or read about these things. And each time you go to the PG course and listen to all these sessions, you actually get updated on what's happening actually. Thank you, Sudhi, once again for the invite.
Thank you very much, sir. Thank you very much, Santosh, and thank you very much, Nair sir. And with your permission, I would like to start. Now I am sharing my screen. So, is my screen visible to everyone?
Yes.
Thank you very much.
Yes, visible.
Okay. So, friends, once again, welcome to our July session. And this time we are discussing about papillary thyroid cancer, a unique tumor. So, friends, now This story begins with a case of a around 55 to 56-year-old postmenopausal lady who initially presented in 2013 with a complaint of a right level 2 cervical lymphadenopathy. At that time, she was advised some investigation from which she had an ultrasound neck done, but no other investigation was done by her because of some family reason, and also because that time those nodes were not that symptomatic. So she this was a story of a 56-year-old postmenopausal lady who initially presented with the complaint of a cervical lymph node in the right level 2. Those she noticed around few years back, 2 to 3 years back, and those were apparently asymptomatic with no clear-cut progression. We advised her the investigation in which she did ultrasound neck that time, but no other investigations was done by her. First, because of she had some family issues, and secondly, those lymph nodes were not that symptomatic, so she did not take them seriously at that time. She presented after 10 years in 2023 with a similar complaint, but now that she has some mild pain and tightening in the lymph nodal area. This time we investigated her thoroughly, which we will discuss in detail. But on clinical evaluation, we could find her thyroid was not palpable, but she had a conglomerate mass of lymph nodes involving the right level to cervical area. Those were partially fixed with the overlying sternocleidomastoid. Jugular vein was not there was no evidence of some vein vascular involvement on clinical examination. The other examination was unremarkable. She did not have any history of childhood irradiation to head and neck. The family history was also unremarkable. So had we asked her for a CT scan, and I request Dr. Meena ma'am to first report, tell us about this ultrasound neck, which was done in 2013, and to show her CT images and explain what she found in the CT scan of this lady.
Thank you, Dr. Sudhi. Slides.
Is it visible now?
No, abhi the slides of the CT are not there.
Are you not able to see, ma'am?
Yeah, now I'm able to see. The ultrasound which was done in 2013 showed ill-defined nodule in the left lobe of thyroid and few enlarged necrotic lymph nodes in right submandibular region. So CT was done at our center. In CT scan, large conglomerate lymph nodes were seen involving along right internal jugular vein, along in suprahyoid hyoid region and extending to right posterior triangle. Nodal mass was invading the right sternocleidomastoid muscle. I want the coronal images. It was this also displacing the internal jugular vein and uh, common carotid artery, and at places fat veins were with internal jugular vein was lost and not seen clearly. And the previous slide, the second slide. Yeah. The right lobe of thyroid appeared to be the atrophic and small nodule seen in the right lobe. And however, as reported in the ultrasound report, we found a ill-defined lesion in left lobe of thyroid showing some cystic degeneration also.
Okay, so now we knew that she had a colloid-like nodular lesion in the left lobe of thyroid. The right lobe of thyroid did not have any significant FNAC-like lesion, but we did an ultrasound-guided FNAC from the conglomerate mass of lymph node. Those were solid cystic. So we got an ultrasound-guided FNAC. We aspirated the cyst, and which was hemorrhagic, around 8 to 10 ml of hemorrhagic cyst we aspirated, and then we took the FNAC sample from the walls. And I request Dr. Chani to describe the FNAC report to us.
Thank you, ma'am. So ultrasound guided FNAC smears were received. So they were from two sides. Few were from right level to cystic lesion. So the smears from right level to cystic lesions were fairly cellular and showed papillae and sheets of neoplastic cells. If we see the first photomicrograph, we can see a papillary structure, and in the second photomicrograph also we can see papillae and which is stretching into a sheet. So The cells in the papillary structures and sheets, they show nuclear elongation, overlapping, intranuclear inclusions, and nuclear grooving. If we see the right-sided larger photomicrograph, the red arrow is showing a intranuclear pseudo-inclusion, and the blue arrow, if we look closely, we can see an oblique groove inside the nucleus. But the smears from thyroid showed blood only and were non-conclusive. So overall, the feature suggested a metastatic papillary thyroid carcinoma in the right level 2 cystic lesion.
Okay, so now we know that we are dealing with the papillary thyroid cancer. We assess the operability of the patient, and with the high risk consent that the IGV, right IGV, may be sacrificed during the dissection, we took the patient for surgery. For us, she had a clinical diagnosis of T2N1B M0 because the subtle hypodensity noticed on the CT scan was not that much appreciable on ultrasound, and we were not able to biopsy that. So we took the patient for total thyroidectomy with central compartment lymph node dissection with right-sided modified radical neck dissection. On the left side, we dedicatedly looked for any pathological lymph node, but we did not find any. These are the intraoperative image. And to mention, intraoperatively, we found very unusually atrophied right lobe of thyroid. That was unusually atrophied, very, very small. However, the left lobe of thyroid was nodular and cut surface was colloid with cystic spaces. This is the look of the that conglomerate mass of lymph node that was in the extreme right level 2, and it was densely adhered with the internal jugular vein, difficult to dissect from it. So ultimately, we had to take a superior excess along with the inferior excess and have to sacrifice the right internal jugular vein in order to have a clear R0 resection of that area. So this is the post intraoperative image following the complete clearance of the right cervical lymph nodes level 2, 3 and 4. This is the gross image. This is the atrophied right lobe of thyroid, the nodular left lobe of thyroid. These are the central compartment lymph nodes. Intraoperatively, we find multiple subcentimeter black colored central compartment lymph node, and we were not sure whether those were pathological or not. But anyhow, the lateral lymph node was pathologically enlarged. And I request Dr. Chani to describe the gross and the microscopic images to us.
We received the gross specimen. As we can see in this picture, the thyroid was pretty small. It weighed only around 5 grams, and size was 4.5 into 2.5 by 1.5 centimeters only. Right lobe was totally atrophic and measured 2 by 1.5 into 0.5 centimeters, and the left lobe was 2.5 by 2 centimeters, and it also showed a nodule. Now, cut surface of the nodule was brownish, hemorrhagic and colloid filled. The rest of the we also received right and left central compartment lymph nodes and the right MRND specimen. So as we can see in the right MRND specimen, the cystic mass at the topmost was there, and this mass measured 4 into 3.5 into 3.5 centimeters. It had a thickened fibrotic wall, and on cut inside papillary projections could be seen. Next one. So if we see the microscopy, first about the cystic mass, the left side larger image, we can see clearly see the papillary architecture, as well as the follicles are also there in the middle. And on the right side, we can see that these papillae were lined by neoplastic cells, which showed nuclear overlapping and nuclear clearing, which is also called orphan Annie eye appearance. If we look carefully, the nuclei seem to be empty inside. So this is an orphan Annie eye appearance. Plus, a lot of psammomatous calcification was also seen, which can be seen in the right lower image. Section internal jugular vein was also found adhered on the outer surface of the cystic mass. So as we can see, this elongated slit-like space this is the internal jugular vein, and surrounding it, lot of fibrosis was there, which was extending from the wall of the cystic mass. Plus, there was the psammomatous calcification was also seen close to the vessel, but the tunica intima and media and the vessel walls were not infiltrated by tumor cells. On examination of thyroid, the right lobe of thyroid was totally atrophic, and the microscopy showed lot of fibrosis. As we can see in the top left image, there's a lot of all this pink area is fibrosis, and atrophic follicles are there. These follicles were lined by non-neoplastic cells which did not show features of a classical PTC. However, as can be seen in the inset, very occasional one or two lumens were there which showed tufting of cells, and they had nuclear enlargement and overlapping. But that is all which we found. And whole of the right lobe was processed, and one cyst was also seen, as can be seen on the right side. And this cyst had macrophages, and this Sanderson poster focus, which we call, which is this group of follicles within the cyst wall. And on the lower side, lower left image is the left lobe colloid nodule, which we were suspecting might be neoplastic, but it turned out to be a colloid nodule with central hemorrhage. So based on all these features, what we found was a classical papillary carcinoma nodal metastasis with thyroid atrophy and occult, likely primary, which could have been a microcarcinoma. And the left lobe nodule turned out to be a colloid nodule. One lymph node was positive, which was the cystic mass. So TNM staging was considered as TX and N1B.
Okay, thank you very much, Ani. So this was the pre-operative image, and post-operatively she had a complete clearance. These are the post-operative image of the patient. Post-operatively, her course was uneventful. She did not have any voice changes or hypocalcemia. Now, with this report of node involving the right lateral cervical region with a size more than 3 centimeter, now she is being planned for whole body radioactive iodine scanning and ablation with a follow-up with TG and anti-TG and suppressive therapy, thyroxine suppressive therapy. For us, she is an intermediate to high risk patient because of multiple factors that we will discuss later on in our session. So, now, why we have discussed this case? Why we want to get this case to be discussed in this forum? So, important is through this case, what we want is to refresh and upgrade our existing knowledge of papillary thyroid cancer. In the sense, we also want to learn about the post-operative management of papillary thyroid cancer. So, as a surgeon, it is very important for me. And not only that, try to understand about the metastatic PTC with occult primary, not only clinically but also pathologically. So, a brief overview of thyroid cancers. Friends, this is a very uncommon cancer representing only less than 1% of all human malignant tumors. However, it represents more than 90% of all endocrine cancers. So, it is the most common endocrine cancer that we see practice. This is the WHO classification 2022. Not going into the detail, just understand that these tumors, these are follicular cell derived neoplasm. And now, if I further simplify this algorithm, then there are four important type of cancers that arise from the thyroid: follicular epithelial cell tumors, parafollicular C cell tumors, non-Hodgkin's lymphomatous tumors, and sarcomatous tumors from the connective tissue. So this papillary thyroid, this follicular epithelial cell, they form two type of tumors. Most importantly is the differentiated thyroid cancer, and there are undifferentiated thyroid cancer in less than 3% of cases. And among the differentiated thyroid cancer, today we are going to discuss about papillary thyroid cancer, which is the most common type of thyroid cancer and most common type of differentiated thyroid cancer, constituting 85% of cases. A bit about differentiated thyroid cancer. Why we call them differentiated? Friends, they are called differentiated because they retain, despite being malignant, despite being cancerous, they still retain the functions of a normal thyroid follicular cells to some extent. They are non-functional. They don't secrete the thyroxine hormone, but they retain the avidity for iodine through their sodium iodine sympathos. They still secrete thyroglobulin, and they are still proliferated by TSH, and all these functions, these abilities, we utilize in managing papillary thyroid cancer or any other differentiated thyroid cancers. Friends, worldwide, papillary thyroid cancer is found in 6.7 patients out of 1 lakh population. In India, the figure is less, 5.4. But we cannot be conclusively rely on the Indian figures because we know how the reporting happens in India. The figure may be high, but we are not sure about it. This is the reported figure. It is the most commonly diagnosed cancer among Indian, fifth most commonly diagnosed cancer among Indian female. So women are more predisposed in the ratio of 3 times more than males. But if there is any nodularity, a discrete nodularity in a male, the chances of malignancy is high in males. So they must be more cautious about it. Usually we find it in the fourth and the fifth decade of life, but we do see childhood papillary thyroid cancers where the lymph nodal involvement is more common, and also in the later stages also we see papillary thyroid cancer. Most commonly, they usually present late to the clinic. Why is it caused? कैसे होता है? Friends, radiation exposure. It is one and the most important causative factor which is been associated with formation of papillary thyroid cancer, especially during childhood. If the patient has received radiation due to any cause, then the chances of malignancy becomes very high. So till 1950s, there was a tendency to give therapeutic radiation to any child or a patient having tinea capitis or enlarged thymus glands or some cancer-related treatment. But later on, they noticed that the chances of papillary thyroid cancer was much high in those children. Apart from that, atomic fallouts, either deliberate like Hiroshima and Nagasaki or accidental like Chernobyl in 1986, occupational hazard, any person engaged in either radiation therapy or radiology or using more and more C arms, they are predisposed for papillary thyroid cancer development later in their life. Because thyroid is the most sensitive, radiation sensitive human organ, and excess cancer occurring at doses as low as 40 milligyri. And this risk increases if this exposure happens younger in age. This effect of radiation persists for several decades, and once exposed in childhood, usually around 20 to 30 years, these patients present in their younger age, like 44th and 5th decade of life. The radiation effect increases in individuals who receive additional chemotherapy, especially in cancer cases. Friends, the second most important etiology is family. So, any patient with a family history of thyroid cancer poses a tenfold increased risk of that nodule being malignant. Be cautious about it. There are certain important germline pathogenic variants like P10 gene, that is phosphatase and tensin homolog, and the syndrome that is associated is P10 hamartoma syndrome. So, what is hamartoma? Hamartomatous tumors, these are disorganized growth of native cells in native tissues. So these cells become non-functional, and if it is present in the skin or subcutaneous tissues, they become visible. And we might have seen such cases in our clinical practice, but now, from now onward, if any patient present to you may not have complained regarding this skin lesion, but have your ears and eyes open that these patients have a very high tendency for cancer development, either in the breast, thyroid, uterus, kidney, colorectal, anywhere. So take all their symptoms very seriously. And this thing we find in Cowden syndrome. So, like cancer develops when any mutation occurs in the genes. So, there is a one very important aspect, that is tyrosine kinase. It is a precursor of cancer formation in papillary thyroid cancer. Friends, we will not go into much detail at this point in time. Maybe later on in some other session, we will discuss in detail about this, and we'll try to dissect and simplify this so that we all understand and implicate in our practice. But for now, mutation or rearrangement of the genes encoding for proteins in the MAPK, mitogen activated protein pathway, protein kinase pathway. It is critical for the development and progression of differentiated thyroid cancers. There are few important mutations that we must know is BRAF V600E, which is most common, 60%. Second most common is RAS, then chromosomal rearrangements like RET, NTRK, ALK 10%, and others 15%. We'll try to understand how important are these, a bit of it, not in detail, later on. So how these patients present? Most of the patient presents with a solitary thyroid nodule, most of the time, either detected by the patient or by attendant or incidentally during imaging workup for unrelated causes. Sometimes we do find multinodular goiter with a papillary thyroid cancer. Sometimes we do find a Graves' disease with a nodule. So, nodule is the most important presentation. Apart from that, there are incidences where we find either a cervical lymph node with thyroid nodule or isolated cervical lymphadenopathy, like in our case. So, or in advanced cases, many times we find thyroid multinodular goiter or a huge thyroid with infiltration to surrounding structures. So those are locally advanced cases. The spectrum of presentation may vary from a slow growing tumor to a rapidly growing tumor with fixity to pathological lymph nodes, extrathyroidal extension to surrounding organs, functional changes, dysphonia, dysphagia, dyspnea. So it has a huge spectrum of presentation. It shows the propensity for lymphatogenous spread much more than the vascular or hematogenous spread. So most commonly, these tumors they metastasize to the local cervical lymph nodes. Uh, Clinically detective lymph nodes are more common in children than in adults. Following surgery, we do find lymph nodal metastasis in 37 to 60% of cases in prophylactic neck surgery. And if we do a modified radical neck dissection, 50% of the tumors are microscopic. Okay, those are not detectable on clinical or radiological examination. Then they may have other presentation like capsular invasion, either thyroid or lymph node with invasion into surrounding tissue in 5 to 35% of the cases, and vascular invasion in 5 to 10% of cases. PTC as such don't metastasize in only 2 to 10% of cases. We see distant metastasis. However, if it happens, most commonly it happens in lungs. Otherwise, in one-fourth cases, it happens in skeleton. Rare sites are brain, kidney, liver, adrenals, and sometimes we see a mix clinical picture with metastasis in multiple organs. But this is very rare. So growth pattern also, as already said, there can be microcarcinoma, occult papillary thyroid cancer. In 15 to 20% of time, we see them during autopsy. Like patient remain asymptomatic throughout their life, and during autopsy we find such lesions. So those are occult PTC. There could be a clinical scenario where there is a large, locally advanced invasive cancer, distant mets, very poor prognosis. And there can be midway also. Like there can be a microcarcinoma with extensive lymph node metastasis, like this picture that is being depicted here. So this lymph node per se is intrathyroidal. It looks like a very benign sort of lesion, but it has a huge lymph nodal metastasis with local invasion. So the here also the spectrum is very huge and very varied. Friends, I just want you to have a closer look of this diagram, this flow diagram. It is very important because it will tell you how we should manage any patient who presents with a thyroid nodule. So important is any patient with thyroid nodule with no previous history of any thyroid dysfunction or thyroid supplementation or replacement, anything like this, always measure TSH. Okay, this is very important because suppose if TSH is normal or elevated, then the chances of malignancy is very, very high in such nodules. How? Though I have not put in the reference, if interested, you can contact me. I can give you a proper reference of this study. But there are studies which show that as the TSH increases, the risk of malignancy is also found to increase. Like if the TSH is more than 5.5 at the time of presentation, the chances of having malignancy in those nodules is up to the tune of 25 to 30%. But and so take those nodules very seriously. However, if the TSH is subnormal or suppressed, then the next step is to do a radionuclide thyroid scan and see the functionality of that nodule. So if the nodule is warm or hot, then the chances of malignancy very less. But if the thyroid is hyperfunctioning but that nodule is cold, it means that nodule is not functioning as per the other thyroid cells, and consider that nodule as abnormal with a high chance of malignancy in such nodule. So following TSH, the next step must be to have an ultrasound neck to find out the anatomical details of that nodule. So it provides more information than a physical examination. It is a very, very important investigation, cheap, readily available, with no radiation hazard. You know, it provides more than 90% of additional information and solves 63% of discrepancies. So apart from the anatomical detail of the nodules and the lymph node, it also provides information about any other additional nodules which are not clinically palpable, their location and site of biopsy. And importantly, it also helps us to select the nodules for FNAC. There could be multiple multinodular goiter. From which nodule would you like to FNA is suggested by ultrasound. So this investigation is of paramount importance in managing thyroid nodules or papillary thyroid cancer. CT scan, MRI neck be reserved for locally advanced case, and for most of the cases, ultrasound neck does our job. Friends, this list we may not go into detail at this point in time. We will, and I promise we will have a dedicated session on thyroid imaging somewhere down the lane. But just note that any lesion which is hypoechogenic, solid, with microcalcification, infiltrative, irregular margin, taller than wider, associated cervical suspicious lymphadenopathy. Manage those nodules with a high clinical suspicion. Those the very high risk of malignancy in such nodules. Pathology is a very important aspect of management of, like, papillary thyroid cancer is a pathological diagnosis. So the pathology plays a very important role in determining how we should manage a patient. So I request now Dr. Chani to describe the pathological features of papillary thyroid cancer.
So papillary thyroid carcinoma, the most common type which we encounter is the classical PTC, which was also the case in this patient. But the WHO 2022 describes multiple other subtypes which are mentioned here, and we will only briefly touch them because it is quite an exhaustive list. First of all, classical PTC, usually they are more than 10 to 15 mm, and grossly they are firm and grey white with infiltrative appearance. Now on microscopy, the classical pattern is characterized by papillary formation, as you can see in the upper photomicrograph, and the nuclear features which characterize PTC, like elongation, overlapping, clearing, grouping, pseudo-inclusions, which we saw earlier. Now some PTCs are less than 10 mm in size, and such PTCs are called microcarcinomas, and on low power they have an infiltrative scar-like pattern. Immunohistochemistry has a limited role in diagnosing PTC. It is usually not required, but certain cases, such as if unknown primary is there, so for such cases we can use TTF1, PAX8, thyroglobulin, and cytokeratins. All of these markers will be positive with PTC. Now, in certain cases, when we are stuck whether the diagnosis is benign versus PTC, certain markers can differentiate, like HbME1, galectin-3, CK19, and CD56. Although all of these markers have limited specificity, so it is better that they are used in combination, because alone they will not be able to give a specific diagnosis. BRAF V600 is a common mutation, and that can also be used in IHC, and it is a very high sensitive and specific mutation for diagnosis purpose. Now just brief relevant points regarding all the subtypes. The first is the PTC solid or trabecular type. This one is more common in children and in post-Chernobyl exposure people and in after radiation exposure. So for calling a solid variant, 50 to 70% or more of the tumor should be solid. A very important DD of this pattern is a follicular, poorly differentiated follicular carcinoma or insular carcinoma. This can be differentiated as a solid PTC will lack necrosis or mitosis. PTC clear cell type, it is very rare but has similar prognosis as a classical PTC. As the name suggests, it has clear cytoplasm, which we can see in the photomicrograph also. Its importance is that it needs to be differentiated from metastatic clear cell tumors of renal or parathyroid origin. A PTC encapsulated, almost 10% of PTCs are encapsulated type and they have a very good prognosis. It is surrounded by a capsule. The capsule can be intact or infiltrated, so the prognosis is much better. This is the PTC infiltrative follicular variant. So this is the second most common after classic and it is more aggressive. Now, as the name suggests, it has almost exclusive follicular pattern. The cells will be disposed in follicle, but the nuclear features will be of PTC. Plus, there will be samoma bodies and sclerosis. As we can see in the photomicrograph also, there is infiltration by regular follicles and they are lined by cells with PTC-like features. PTC tall cell type, it is relevant because white cell having 3 times the width and motility of cells in the tumor should be, but tall renders a poor prognosis and aggressive scores. Even if more than 10% cells are 50%, then also they should always be mentioned in the report. This is the PTC columnar type. It is also a rare aggressive, it is also an aggressive variant and it shows nuclear pseudostratification and some nuclear vacuoles. It will resemble the endocrine malignancy on histopathology. And the thing is that most of the subtypes of PTC will show classical PTC nuclear features, but this variant will not show classic nuclear features. Ma'am, next. PTC oncocytic type, it is very rare, and as the name suggests, the cells are oncocytic. Cells are oncocytic with abundant eosinophilic cytoplasm. The nuclei, if we see in the photomicrograph, again, they are the clear ones, orphan eye appearance with elongation. But the cytoplasm is abundant eosinophilic oncocytic type. Next is the hobnail type. It is also an aggressive variant in which at least 30% of cells should be hobnail micropapillary pattern. Hobnail is called when the nucleus is, as we can see in the photomicrograph, nuclei are protruding in the lumen and they give a hobnail appearance like hobnail roots. So from that, this terminology has come. Then PTC Warden-like because it resembles the Warden tumor of salivary gland. So similar to that, the papillae are lined by oncocytic cells and the papillae are rich in lymphocytes and plasma cells. It has a favorable prognosis. And then is this spindle cell type, it is a very rare variant and more than 50% of spindle cells have to be there and these cells will show PTC nuclei. If you see in the right photomicrograph, the nuclei have features of PTC but the cells are spindled morphology. And as it is very rare, data is lacking regarding prognosis. PTC is subtype with desmoid type fibromatosis. In this, if we see the photomicrograph, we can see abundant spindle cell stroma. With the stroma will be cellular and it will resemble the myofibroblastic processes like podulofasciitis, fibromatosis, and such. So tumor cells, we can see compressed cords are there. So it has to be differentiated from fibroblastic tumors. And PTC diffuse sclerosing type, it is an uncommon and aggressive tumor. Again, this one is more common in children and after radiation exposure. There should diffuse involvement of both the lobes. Clinically, it will give a hard appearance like we see in Weevil's thyroiditis. It can give such a clinical feature. And it will, on microscopy, there will be sclerosis, samoma bodies, squamous metaplasia, and the background of the chronic thyroid. Some of the relevant mutations which we find in PTC, most common mutation is the BRAF V600E. BRAF is a proto-oncogene which encodes a serine threonine kinase cytoplasmic component, and mutation, a missense mutation causes many malignancies, among which is PTC also. It is the most common in PTC. It is a very powerful diagnostic marker also because it is highly sensitive and specific. and it has a strong association with tall cell variant. Almost 90% of tall cell variants are positive for this mutation. It can be detected by IHC or sequencing, for which peripheral blood can be used. Sequencing is always considered better in molecular. Prognostic significance of this marker is molecular mutation is controversial, but it has a predictive benefit for therapy with kinase inhibitors like dabrafenib and vemurafenib can be used for locally advanced PTC. Second common mutation is a red PTC, that is mutation in the red proto-oncogene. It is a this gene encodes transmembrane tyrosine kinase receptor, and the relevance is that this mutation is found in PTCs in children and young adults and radiation exposure related PTCs. As this mutation is common in children, so that is why it is also common in solid variants, which we read earlier that solid variant is also more common in children and post-radiation PTCs. There are other tyrosine kinases also, and mainly relevance is for targeted therapy like ALK inhibitors, crizotinib can be used. Molecular in PTC has limited advantage for diagnosis, but more in terms of management for locally advanced malignancies.
Thank you very much, Chani. And now we know a brief about the various pathology. Basically, papillary thyroid cancer is a diagnosis based on the nuclear features, and there are various variants. The most important thing, which is common among all the variants, is that the nuclear features are same. Okay, so how do we manage a patient with a papillary thyroid cancer? The papillary thyroid cancer management is based on three important supports. Uh, but the first and the foremost is the surgery. Surgery is a very, very important part and the of managing papillary thyroid cancer. Following which is the TSH suppression and radioactive iodine therapy. So we will see the details of each modalities one by one. There are other therapies also like tyrosine kinase inhibitors and external beam radiation therapy. Those are being done in cases where the differentiated tumor has become de-differentiated. So we will not cover those aspects in this session. Maybe somewhere later in our sessions, some other time, we will discuss about those. So now coming to surgery. Being a surgeon, this is the most important aspect for me how to manage it. So we know preoperative imaging is very important. First to know about the primary tumor features as well as to know about the extent of lymph node involvement. Most of the time, our work is done with ultrasound, preferably. This ultrasound or any imaging may alter our surgical planning by detecting some additional abnormal lymph nodes in 20 to 30% of patients. Not only that, like the ultrasound may miss around 50% of involved central compartment lymph nodes because of the overlying thyroid and sternum that we can understand. Additional imagings like CT scan, MRI, endoscopy, they are considered most of the time in a locally advanced disease with suspected visceral infiltration and is done on a case-to-case basis. So there are two type of procedures. First is to completely remove all type of thyroid from the body, doing a total thyroidectomy. Sometimes some surgeons, in order to save the recurrent laryngeal nerve, they leave the posterior capsule deliberately or leave a small amount of thyroid at the ligament of Berry, which we term as near total thyroidectomy. Friends, but in experienced hand, experienced endocrine surgeon, oncosurgeon, the chances of complications are very, very less. And if at all you're given a choice, always go for total thyroidectomy. Then the other surgical approach is hemithyroidectomy, where we do a unilateral lobectomy with isthmectomy. Please understand from now on, subtotal thyroidectomy is an inadequate surgical procedure and it is not at all recommended. So in whom we should consider hemithyroidectomy, in whom we should consider total thyroidectomy. Any lesion like less than 1 centimeter tumor, intrathyroidal with no extrathyroidal extension, no lymph nodes, you can upfront go for a hemithyroidectomy. It is a preferred approach. However, any patient with a suspicious lesions in the contralateral lobe, multifocal micropapillary thyroid cancers, or a previous history of head and neck irradiation, or a strong family history of thyroid cancer, there is a very high chances of developing cancer in the contralateral lobe. So it is always advisable to go for an upfront total thyroidectomy, which is also advocated in patient in whom we feel that the patient may have a difficult follow-up, so may be difficult to look for any recurrences in the contralateral lobe. Upfront go for total thyroidectomy. It is a safer procedure. Now, suppose the tumor size is 1 to 4 centimeter. It is enlarged in size, but it's still less than 4 centimeter. Then, if it is without extrathyroidal extension, no lymph node, you can choose between either total thyroidectomy or hemithyroidectomy. It is equally preferred. But in the previously suggested high risk features like suspicious lesions in the contralateral lobe, previous history of head and neck irradiation, strong family history, difficult follow up, we prefer doing total thyroidectomy over hemithyroidectomy. Not only that, if we feel that there is some benefit of receiving radioactive iodine therapy, always consider for total thyroidectomy, because if there is a significant amount of thyroid tissue in the neck, we may not be able to give a radioactive iodine therapy in such cases. So remove all thyroid tissue from the neck. So now, if the tumor is more than 4 centimeter, whether it is extended extrathyroidally or there are lymph node metastasis, irrespective of it, if the tumor is more than 4 centimeter, go for total thyroidectomy. If there is a history of childhood head and neck irradiation or a family history, irrespective of tumor size, go for total thyroidectomy. If it is a multifocal primary micropapillary carcinoma, like more than 5 foci, go for total thyroidectomy. But there can be instances where patient is operated for an apparently benign thyroid nodule, hemithyroidectomy is done, and the lesion is detected as having papillary thyroid cancer. Now, what to do? Please don't worry. Just see if there are foci less than 5, don't worry. Hemithyroidectomy is sufficient and just closely follow the patient. But if the foci are more than 5, then certainly you have to counsel the patient and then go for completion total thyroidectomy. Okay. Now something about lymph node dissection. So there are two types of lymph node dissection that we do in a papillary thyroid cancer. First is a therapeutic, where we know that there are clinical or imaging proving nodal mets. Because if we do a therapeutic lymph node dissection, we completely remove the involved lymph node. It gives us a disease-free and overall survival advantage. However, there are provision of prophylactic central compartment lymph node dissection, which is still controversial, because studies have found there are 80% of cases which have microscopic level 6 metastasis. Those are microscopic metastasis in an apparently localized disease. But these microscopic central compartment lymph node metastasis is rarely of clinical importance, because they can be largely ablated with the adjuvant radioactive iodine therapy and may not improve overall survival. But they may increase the risk of inadvertent parathyroidectomy and recurrent laryngeal nerve injury, leading to permanent hypocalcemia and permanent hoarseness in such patients. So, prophylactic central compartment lymph node dissection must be considered judiciously in patients who have an advanced primary tumor with extrathyroidal extension with involved lateral cervical lymph node, or if the information can contribute to further planning. Now, following surgery, what we do is to stratify the patient. We risk stratify the patient. There are two important ways through which we do it. First is the ATA risk assessment after surgery, and another is the TNM staging, that is AJCC 8th edition. So I'm just giving you an overview how we actually do it, and I will try to simplify it for our audience. First of all, any patient less than 1 centimeter lesion, intrathyroidal with less than 5 lymph node, micrometastasis with the largest diameter less than 0.2 centimeter. These are low risk patient. Any patient with gross extrathyroidal extension, incomplete tumor resection, distant metastasis, or lymph nodes more than 3 centimeter, these are high risk patients. Intermediate are those where there is some aggressive histologies like tall cell variant, solid, trabecular that Dr. Chani has described. There is some microscopic extrathyroidal extension. The lesion is R0 or R1 dissection is done, but there is some minor extrathyroidal extension, microscopic invasions are there, vascular invasion is there, or more than 5 lymph nodes with a maximum diameter around 0.2 to 3. So in between somewhere is the intermediate, otherwise low and high. You just remember low and high risk, and the rest is the intermediate risk. So this AGCC classification or TNM staging, as such, if you see in the internet, you will find a very broad list. Now, through this chart, and I request you please save this chart, please just simplify how it is being done. So please, less than 55 years, only two stage 1 and stage 2. If the patient has metastasis, that patient is a stage 2, NET, NEN. If the patient does not have any distant metastasis, it is stage 1. It is as simple as that. However, if the patient age is more than 55 years, if the patient has a evident distant metastasis, the patient is stage 4B. If the patient does not have evident distant metastasis, then look for extrathyroidal extension. If it is not there and the tumor is less than 4 centimeter with no lymph node, it is stage 1. But the tumor is less than 4 but has lymph nodes, it is stage 2. Tumor is more than 4 centimeter, it also is stage 2. So any tumor more than 4 centimeter or any patient with lymph nodal involvement, they are stage 2. Now, if there is a microscopic, if there is only strap muscle involvement, it is stage 2. But if the thyroid has an extrathyroidal extension with involvement of trachea, esophagus, recurrent laryngeal nerve, or larynx, it is stage 3. And if the patient, the extrathyroidal extension has involved the prevertebral fascia, major vessel, mediastinal vessels, then it is stage 4A. So, this is how we stage the patient following surgery. Now, how we monitor such patient? Three important parameters that we usually see in such patient: unstimulated TG 4 to 6 weeks, 4 से 6 हफ्ते, 3 से 6 महीने और 9 से 12 महीने in all the patients. Just measure unstimulated TG without any anti-TG. Then serum TSH, measure it at 4 to 6 weeks, 3 to 6 months, and 9 to 12 months, and see if the TG is undetectable, that is within the normal reference range, then try to maintain in a low risk patient a TSH of 0.5 to 2. But if the TG is detectable or the patient is intermediate risk, then our target goal is 0.1 to 5. And if the patient is very high risk, try to maintain it within less than 0.1 for at least the initial first year. Neck ultrasound we ask was at 6 months and 12 months. Diagnostic whole body scan, in low risk, usually it is not indicated. However, in intermediate and high risk, we do it on a case specific manner, case to case basis. MRI, we don't do until unless we think, we suspect that there is elevation of TG which is inappropriate and there is a high clinical suspicion of recurrence. And on ultrasound, we are not able to get any finding, then we may ask for an MRI or CT scan. PET scan is also not indicated until we find that the TG is more than 10 nanogram per ml. This we will discuss in our subsequent slides in detail. So friends, TSH suppression is our next support. Why it is important? Post-operatively, thyroid hormone therapy is required. First, we have removed the thyroid. So patient needs some replacement hormone therapy. This we provide with exogenous levothyroxine, exogenous thyroxine. Also, additional dose we give to the patient to suppress the tumor regrowth. So LT4 is immediately started in the post-op in a low and intermediate risk who are unlikely to receive radioactive iodine scanning and ablation. However, in an selected intermediate and high risk patient, we usually don't start the levothyroxine therapy immediately in the post-op. We just plan for the radioactive iodine scan and ablation with the help of our nuclear medicine physicians, and accordingly we plan the date, and accordingly then we start the levothyroxine therapy. If we think that our dates are long, then we may start. If we get an early date, then we may not start the levothyroxine therapy in such cases. Because why we set the goal? Because like in a low risk patient, if you suppress the TSH to suppose less than 0.1, then you are unnecessarily exposing that patient to high thyroxine level, which may lead to cardiac dysfunction and metabolic bone disease, which is not desired. Because excessive doses of levothyroxine may also pose some side effect, and a long duration of such exposure may decrease the health of the may harm the health of the patient. So we have to be very judicious in selecting the patient in whom we have to provide a thyroxine suppressive therapy. Now about the radioactive iodine therapy. This is one of the most important support in management of papillary thyroid cancer, and I request our colleague Dr. Reena Damija to tell us something about this radioactive iodine therapy and PTC management.
Okay, thank you, Dr. Sudhi. Uh, this thyroid cancer patient usually reported to our nuclear medicine department post-operatively, post total thyroidectomy, for radioactive iodine scanning and successive ablation therapy, etc. Next slide, please. So, why iodine important is because basic metabolism, if we can see, this iodine is absorbed from GIT into various organs, mostly into the thyroid gland. In thyroid gland, it is actually enter into thyroid follicular cells along with sodium ion. That is sodium iodide transporter system called NIS, sodium iodide importer. And along with sodium, it enters into thyroid follicular cells and then incorporated with thyroglobulin and forming thyroid hormone. So this is normal metabolism. This radioactive iodine, what it does, it follows same route and that enter into the thyroid gland and kills the thyroid cancer cells because NIS is overexpressed in cancer tissues. Next slide. About indication, ATA recommended certain cases where all the patient needed this RAI ablation is known distant metastasis, then gross extrathyroidal extension, regardless of the tumor size, and of course, primary tumor size more than 4 centimeter, and also if there is presence of Harris feature. So they all need the RAI ablation. ATA also recommended few or selected cases like 1 to 4 centimeter thyroid cancers, means size, and they confined to the thyroid with documented lymph nodal metastasis or combination of some high risk features like presence of intrathyroidal vascular invasion or multifocal disease, gross or microscopic. Goals of RAI. Goals is remnant ablation to facilitate detection of recurrent disease or I can say initial staging. Then adjuvant therapy that decreases the risk of recurrence, and RAI therapy definitely for persistent disease. There are various isotopes available of iodine. Most important is I-131. It is having half-life of 8 days, and this isotope is specifically called theranostic because 10% of gamma emitter that helps in diagnostic or we can do imaging, and 90% beta emission that is help in therapeutic. These iodine is usually available for oral ingestion, either capsule or solution. Capsule usually in microcurie form, and solution we can fractionate easily, though capsules we cannot fractionate. These are rapidly absorbed from upper GI. And this is, as I said, apart from thyroid, it also goes into certain other organs. That is called physiological uptake. So it is going into salivary gland, then urinary bladder, and whole of the GIT. And also, it also goes into the certain contraindication. Absolute contraindication is pregnancy. So we have to rule out pregnancy before giving iodine. And also, if nursing mother is reporting, then breastfeeding has to be stopped just before giving iodine. Certain relative contraindications like bone marrow depression, pulmonary fibrosis may occur, so function restriction, salivary gland dysfunction like xerostomia and all, and certain hepatic and renal dysfunction also may occur. So before giving radioactive iodine, we need some protocol, some basic blood test. Most important is TSH, TG, other routine blood tests, of course, and also the beta HCG just to rule out pregnancy. First, I will be talking about TSH. So TSH for radioactive iodine, it should be more than 30 because at this level there is NIS is overexpressed and iodine uptake will be occurred. So this can be achieved one of the three ways. One is the most common we are using is thyroxine withdrawal. So we are doing altroxin to be withdrawal 4 to 6 weeks prior to the scanning or ablation. If patient is not capable of doing such a long off the altroxin, the another protocol we are using is to put the patient on T3 formula and then withdraw this T3 formula 2 weeks prior to the ablation and go for the iodine and all. Before giving iodine, we need TSH and TG just to confirm TSH should be more than 30. And the third way is to increase TSH is giving recombinant human TSH. This is injectable. This is very costly. Rarely we are using in our department. For RAI to be given, uh, once we have seen the TSH is comfortable, we are giving iodine. But before that, we have to give the instructions to the patient that patient should avoid iodine containing foods, medicine, and certain radiological investigation around 15 days before we are going for scanning. Pregnancy, I already told you. Breastfeeding, I also told you. And in our department, we need isolation ward. Isolation ward is required only after therapy, not after scanning. So if we are giving therapy, then patient has to be keep in isolation till the level of radiation falls to a certain limit that patient can come into the public. So after TSH level reach more than 30, we'll give radioactive iodine orally. It should be given in doses 1 to 3 millicurie or up to maximum 5. Should not be given more than 5, otherwise thyroid tissue may get stunned. After giving oral iodine, we sending the patient back home, calling the patient after 48 to 72 hours, and we are doing whole body scanning. This whole body scanning, this will show whether uptake is only into thyroid bed or certain distant metastasis. We'll decide after that. For patient to be put to the thyroxine and regular diet, 5th or 6th days post iodine dose, only if therapy is not required with iodine. Otherwise, should be withhold. And dose is depending on what we see into the iodine scan. If only residual thyroid tissue is there, the dose is 30 millicurie. If other metastasis like lymph node metastasis, 100, lung metastasis, 150, skeletal is the highest, 200 to 250 millicurie. All these require isolation ward and delay time so that patient's excreta through which iodine is excreted out should not be come into the main sewerage. That has to be kept separately, allowed to decay. And after decay, around 3 months. After that, we'll discharge into main sewerage. This is how whole body iodine scan looks like. This is already labeled. These all are physiological uptake like salivary gland, GIT, bladder. Urine is the excretory route for the iodine. And one abnormal uptake you can see in the neck. That is thyroid remnant or residual tissue. Another second image that is showing multiple focus at the level of neck. So this is most likely lymph nodal uptake. Apart from that, physiological uptake you can see in GIT and bladder. Last image that is showing some uptake into lung field also. So that is most likely lung uptake. We cannot exactly differentiate it anatomically because this is only gamma scan, not the fusion scan. If it could be a fusion scan, we can clearly say that this is in lung. So as this is a radioactive isotope, some certain radiation safety protocols need to be followed. This RAI mainly excreted through urine, also from other body fluids. So after taking radioiodine, patient when goes to home, we usually advise them to keep distance of approximately 1 meter from family members, and should avoid close contact with the children less than 5 years. If any pregnant lady inside in the home, should be make proper distance. Should not share toilet, bathroom, food, bed, linen, and all fomites like that. Wash hands, and need to take more and more water so that it is excreted out from the general body. We want only iodine to be retained only into the thyroid tissues. Side effects, otherwise minimal side effects, but if occur, immediate side effect, nausea, gastritis, dry mouth is more important, like xerostomia. So we are just advising patient to take more and more water, and still if they feel dry mouth, take lemon or lemon juice or lemon candies. They all treat actually xerostomia. Side effects like bone marrow suppression, pancytopenia, leukemias. This is radiation, nothing else. So all these hypospermia and fibrosis, I already told you. Secondary malignancy may occur. Chronic adenitis and xerostomia. Follow up. First scanning with radioactive iodine, whatever we see in the neck is most likely residual normal tissue. And in presence of normal tissue, we never see uptake into the cancerous tissue that may be present in distant places. So first scanning may whatever we are seeing in we just see the percentage uptake, and we'll give radioactive iodine to that particular patient around 30 millicurie. We usually does this, and subsequent scans, yeah, you can say post therapy scan. After giving 30 millicurie, we usually go for post therapy scan whenever the radiation level comes to a comfortable level that patient can come into the public. And that time, because diagnostic scan we have given only 1 to 3 millicurie. For therapy we have given 30 millicurie. So definitely, if there is we are suspecting some metastasis, we can see. So post therapy scan, usually we see more sites of this iodine uptake. This has been documented. Okay, successful remnant ablation हम कैसे कह सकते हैं that absence of visible uptake and subsequent scanning, which we are doing usually 6 months after first dose, and also undetectable TG. This is 50 millicurie I-131 given to the patient, and you can see the post-therapy scan. There's only neck uptake you can see. This first one is the post-therapy scan that first time has been given iodine therapy, and post-therapy mein you can see only neck uptake. That means other distance metastasis definitely absent होगा. Then ये post follow-up scan है whole body. You can see only physiological uptake in salivary gland, stomach, GIT, bladder. So that shows कि iodine ablation is successful. Challenges come in treating with iodine therapy. One is Tennis syndrome. This is TG elevated negative iodine scan. Whenever we are doing iodine scan, but TG is already elevated, but iodine scan comes negative. This particular condition is called de-differentiation. That iodine is not taking up. Maybe NIS, sodium iodide importer, is not expressed. That's why iodine uptake has not been done. So in that case, need FDG PET scan, but TG should be more than 15. More than 15, go for FDG PET scan. And if that comes positive for metastasis, this is called de-differentiation. And here iodine therapy may not be benefited. Second challenge comes is redifferentiation, that is RAI refractive DTC THAVO. And finally, when we are giving certain targeted therapy, we can say, that is tyrosine kinase inhibitor, these actually increases the NIS receptor on the cells. And following that, if we are giving iodine therapy, that is beneficial.
Thank you very much, Dr. Reena. Was such an elaborative and comprehensive detail that you have provided about the radioactive iodine therapy that is being given to PTC patients. So, friends, most of the patients with PTC don't die with the disease, though they have recurrences in the local regional level. They may have multiple nodal lymph nodal recurrences, but majority of the patient don't die with the disease. There are studies with a follow-up of 16 years, 20 years, which showed that the cancer-specific mortality, especially in a localized disease, was only 6%. That is like 16 to 20 years, but 20 years survival is more than 90% in localized disease. So thyroid cancer is one, especially differentiated thyroid cancer is one such cancer where we talk about the 20 years survivability in terms of more than 90% or at least more than 80% in an intermediate risk or some high risk patients. But there are certain factors which favor mortality, which are not very good factors. First of all, is the age. So, disease specific mortality increases with the advancing age. That we have already seen in the AJCC-TNM classification. Survival remains more than 90% for patients remains more than 90% for patients under 65 years of age at the time of diagnosis. The next important factor is the tumor size. So, as the size increases, the mortality rate increases in the patients. So, there was one study which monitored the tumor size with the mortality rate more than 7 centimeter. The mortality, the 10 to 20-year mortality, disease specific mortality was in the tune of 40 to 50% in certain series. Lymph node involvement, distant metastasis, they all contribute to the poor prognosis of the patient, especially when that tumor size is also high. Soft tissue invasion, extrathyroidal invasion, no need to mention. Agar there is a more extrathyroidal extension, the more chances of mortality in such patients. Microscopic invasion per se is not a major factor for mortality. However, a gross extrathyroidal extension is certainly a poor prognostic factor. Distant metastasis, the mortality depend upon the site and the extent of metastasis. Like suppose there is single pulmonary focus, the 10 years survivability is still 30 to 50%. And it is still higher if it is detected on radioiodine imaging, because first of all we can ablate those lesions, and secondly those lesions are usually asymptomatic. If the lesion is in the brain, then the median survival is approximately 1 year, because these patients usually present with a high intracranial tension and subsequent and the complications due to that. FDG positivity means that the tumor has de-differentiated. It is not taking iodine. That is why it is now more FDG positive. So it is a most powerful predictor of death. So in any patient now, if the TG is more than 10 to 15, and we are asking for a PET scan, it itself confers that the prognosis is not good, and the disease specific survival is less than 50% in 3 years. Other high risk factors are multicentricity of multicentricity, extent of lymph nodal involvement, mediastinal lymph node involvement, lymph nodes more than 10, nodal metastasis with extranodal extension, male sex, and delay in primary surgical therapy for more than 1 year following tumor detection. Then certain histological subtypes, as Dr. Chani has elaborated, just to name a few: tall cell variant, insular, hobnail, solid variant. These are all aggressive histological subtypes. So keep them in the intermediate group and high group and treat them aggressively, so that to hit them at the first instance only, so that they don't recur. Then certain molecular characteristics like BRAF, TERT, telomerase reverse transcriptase, VEGF, they predict risk of extrathyroidal extension and lymph node metastasis and even distant metastasis. However, whether we should screen these molecular markers on a routine basis, it needs further validation. If I can briefly describe like how now patient has received all the treatment, how we should now stratify the patient. The patient can be stratified as excellent responders, biochemically incomplete responder, structurally incomplete responder, and indeterminate responder. So, what is excellent response? A patient with total thyroidectomy with radioactive iodine ablation. Now the ablation is being done. So what we expect that unstimulated TG must be undetectable, that is less than 0.2 nanogram per ml. Or if we are stimulating the TG, it should not be more than 1 nanogram per ml with undetectable thyroid globulin antibody and with negative imaging. So these are excellent responses. Same with, like, suppose a patient did not receive radioactive iodine therapy, then unstimulated TG should be less than point. It should be less than point. With radioactive iodine, it should be less than 1. Without radioactive iodine, it should be less than 0.2. So this is the thing. If it is lobectomy, unstimulated TG should be less than 13 with undetectable TG thyroglobulin antibody and with negative imaging. In this case, we don't do radioactive iodine scan. With the normal ultrasound, we follow up the patient. Now, biochemical incomplete response. That is a tennis syndrome, which Dr. Reena has described. When there is an unstimulated TG less than 1 or stimulated TG less than 10, so it is raised with increasing thyroglobulin antibody with negative imaging. So thyroglobulin, this TG is raised, but there is a negative imaging. This is called tennis syndrome. With radioactive iodine scanning, uh, without radioactive iodine scanning, the level of TG is kept a bit high. That is, if it is more than 5 unstimulated, more than 10 in stimulated, with increasing thyroglobulin antibody and negative imaging. And lobectomy may, if it is more than 30 with progressive rising TG level for the same TSH or increasing thyroglobulin antibody with negative imaging. So if the thyroglobulin level increases, but we don't find any lesion, a localized lesion on imaging, either on radioactive iodine scanning or on conventional imaging, then we term that patient as having a biochemically incomplete response. Structurally incomplete response, when we see some structural problem, some evident tumor, a local recurrence in the neck of the patient, regardless of thyroglobulin or thyroglobulin antibody, that patient has structurally incomplete response, and these patients are amenable for surgical resection of that particular lesion that is causing the problem. Indeterminate, like, there is a combination of findings between excellent response and a biochemically incomplete response, and we are not able to understand. Like, suppose the patient has an unstimulated TG of less than 0.2, but the stimulated TG is approximately 10. Then we may get confused, like which point to consider the most. So these are called indeterminate. There are instances when we do get mixed response. So now, if we apply the current in the whatsoever we have discussed on a current case, this patient as such is a high risk case, at least intermediate to high risk, because she is more than 55 years with a long standing disease. She deferred her treatment for more than 10 years with a lymph node, a lateral cervical lymph node more than 3 centimeter. Uh, though histologically the vascular invasion was not identified, but it was very densely adhered to the internal jugular vein. We may omit this point, but keeping the other points in mind, it was a apparently locally advanced disease. So at least I would certainly like to keep this patient as a high risk. Adjuvant therapy, what I would like to plan is to keep her thyroxine suppression below zero point 0.1 or at least 0.5 to zero point 0.2, at least in her case, with the whole body radioiodine scanning and ablation with 100 millicurie at the earliest. So, as such, we have not started the TSS suppressive therapy for now, and we have applied for radioactive iodine scanning and ablation, and possibly our nuclear medicine physician may also agree with this interpretation of whatsoever we have discussed. So now, may I request you to please comment on the case and the discussion that we had till now.
Thank you very much for an interesting talk. Now, if anyone has any question, I hope our faculty and panelists will be delighted to answer them. Any questions, please?
Okay, so there is very important, very interesting. Like, when we were discussing, we were planning our case. Now, the last slide that I have put regarding what I have said, like, of the structures with the surrounding of the lymph node with the surrounding structures. Though our pathologist did not find any evident vascular invasion, but it was there. So for me, there is a conflicting evidences. This lady had a tumor. She's she's more than 55 years. So with a tumor for last 10 years. She's more than 55 years. She has an apparent extrathyroidal extension, at least to sternocleidomastoid and other. It could be because of multiple intratumoral hemorrhages leading to fibrosis, or it could be a sequelae of the disease. I'm not sure. And for me, she's a high risk case. So, do you all agree she's a high risk, or would you like to keep this patient in the intermediate risk category? Because she remained asymptomatic for past 10 years. As such, the disease did not progress to that extent, which usually if we leave the disease progresses with so much extent. But in this case, it did not happen. So, how aggressively should we manage this case? Should we keep it as a high risk, or we keep it as intermediate risk? At least I think it is not a low risk disease.
Okay, Dr. Sudhi, shall I comment on this?
Sir, please.
Now, if the lesion that was detected some 10 years back was the same lesion, I would put the patient into a low risk category, because over the years the disease has not spread. It has remained in the node. She doesn't have any distant metastasis except for a local aggressiveness. Nothing else has happened. So I would, rather than going by the conventional way of thinking about it, just taking into consideration the age of the patient and the invasion, I would think that it has not behaved like an aggressive tumor. 10 years have passed. There is no metastasis, no lesion anywhere else as per your nuclear scan, and the thyroglobulin also is quite favorable. So I would put it that way. What is interesting in this case, what I find is that there was no primary detected in the thyroid. That is the most interesting thing for me. And being a right sided nodal basin that has been affected, one would expect a nodule on the right lobe of the thyroid. And interestingly, that was atrophic. I would feel that there is one possibility is that she had extensive thyroiditis. And I don't know whether the pathologists have identified any thyroiditis in the remnant right lobe, but that can explain actually if there was thyroiditis, which we see quite often in our patients. The gland would undergo atrophic changes later on, and when you dissect, you will find that it's grossly atrophic and there is hardly anything. And the carcinoma that would have happened there would have been a microcarcinoma, matlab less than even 5 millimeters, because the sections they take is, I think, I understand, is 5 mm. And if it is less than that, a smaller tumor. And in that case also, it is a low risk, less aggressive tumor, because that tumor has not surfaced in the last 10 years. It has remained there and it has disappeared. One more possibility sometimes people say is that the lateral swelling which you detected was an ectopic thyroid, in which the thyroid malignancy has happened. And therefore, in the primary neck, you are not, in the thyroid, in the utopic location, you are not seeing anything. That is a way of explaining that if you don't see the primary in the thyroid. So this was a lateral thyroid, a normal thyroid tissue in an ectopic location in which the malignancy has happened. That is why it has spread locally. And there were other nodes were negative in that area. And thyroid metastasis from thyroid gland would have spread to some other node. You had only one node out of the 17 positive. Then that one node was the cystic lesion in the upper neck. So one possibility is that probably it's an ectopic thyroid tissue in which the malignancy is developed.
So I think you have put in a very, very important point, because our next question was regarding the occult PTC only. And a few important findings that we got in this case was that it was atrophied. And you very well explained that it could be a possibility also. I'm not sure. Jani can tell whether she found any features of thyroiditis, or maybe those features have also subsided with time, leading to fibrosis.
Sometimes in the late thyroid, not find active inflammation or plenty of lymphocytic, but in late stages it can just present as fibrosis. As in this case, it may be a late stage of chronic lymphocytic thyroiditis, because it is one of the prominent cause of atrophy of thyroid. So that is a possibility that it can be a.
The next question arises: is it a possibility like the thyroiditis happened in only a single lobe, and the other lobe remained unaffected? When
Now, the thyroiditis, when it happens, it usually generally affects both sides. It affects the entire lobe, entire gland. But you sometimes you will see that the thyroiditis is not equally distributed in both sides. One side it is more, and other side it is less. We have seen like that intraoperatively when we operate these patients. We find that there is a nodule on one side, but the opposite side, when we just check whether there is any nodule or not, we find that there is dense thyroiditis there. So you do the total thyroidectomy in such patients. We have had several occasions. So the thyroiditis may not be equally distributed. And remember, thyroiditis is an autoimmune disease, and the body itself auto corrects the process. What has gone wrong. And so, if the thyroiditis was florid on one side, and the other side has just taken off, and the recovery process has initiated, the recovery will be better on the side which is not affected, and the side which is initially completely affected will show a lot of atrophic changes. So, in the bargain, you can have, but though rare, even though it is classically described that it start both sides simultaneously because autoimmune, antibody mediator, etc., etc. But it can start from one side more than the, just like you see exophthalmos, you see one side more, then it comes bilateral, or sometimes you see both together.
yeah, certainly, certainly. Your points are very valid and well taken, sir. So one thing important, like just want to share, like Santosh, you can also contribute, or any other person would like to give their inputs. Uh, Suppose there is a possibility of ectopic thyroid tissue in the right lateral cervical. Is there anything like before developing PTC, we can identify such patient due to any means, or like only after development of a tumor then we think that it could be a necrotic tissue, something like case like this? Or is there anything, do we have any series, any of your exposure related to this ectopic thyroid? So that like so pyramidal lobe, we remove many times pyramidal lobe because we know that chances of PTC very high in pyramidal lobe tumors. So is there something like we can detect, or have you seen any such patient where we found an ectopic thyroid like tissue, something abnormal tissue in the neck, and before development of PTC, any thyroid tumor? Or we just predict like it could be because of ectopic thyroid?
Dr. Sudhi, this is a rare scenario what we are dealing with. We have seen that in submental regions. Recently, I have a girl who is having a large swelling in the submental region. She is hypothyroid also, but thyroid tissue. And also lateral neck also we have seen, but we have always taken it as a metastasis. But in that cases, we have had lesion in the thyroid also. But here is the situation. Now, all the more I feel like it is ectopic thyroid tissue because for 10 years she has been having the swelling, and the initial she has nothing, no, except for the swelling, no other symptom. Now, of late, she has developed symptoms. Probably now the malignancy developed now, not at that time, 10 years back. Probably it developed now in the ectopic thyroid tissue. You can think like that also.
Yeah,
But I don't have experience in much in that. But this is a way of putting things when the thyroid is exactly normal and such a long history of 10 years. So you can say that there was a palpable swelling there, which was an ectopic thyroid. Now there is a malignancy in that. And correct me if I am wrong. I'm just
no,
putting
no,
a hypothesis.
not at all, sir. Because like with discussion only, we come to know about each. We come to know about the things. Like we gain knowledge from each other only. Until unless we discuss about, we cannot understand. We just think in ourselves. Okay, so this is the thing. Sir, any would you like to share? Or Santosh, you can also. Have you? What is the role of frozen section biopsy in papillary thyroid cancer? Is it really advisable to? Are you doing it at your center, or any experience you would like to share?
But if Sudhi, if it's to me, if it's to me.
Mhm. Yes, sir. Yes, sir. Please.
So, in papillary thyroid cancers, if we have a FNAC diagnosis of papillary thyroid cancer involving one lobe, then usually we don't go for any frozen section during surgery because the preoperative ultrasound screening would have done, and it would have shown to you whether there's any lymph node or not. Now, if you have a papillary thyroid cancer FNAC from the thyroid and the ultrasound shows a suspicious node, certainly we go for a frozen section during the surgery. Similarly, if the ultrasound findings are very suggestive of a TR5 lesion in the neck, the TRAS5 lesion, but the FNAC has failed to say that it is malignancy, or it has stopped short at AUS or FLUS, or it has gone for a follicular neoplasm, then I will add a frozen section in follicular neoplasm to look at the follicular variant of PTC. Whereas in the FLUS and AUS with a TR5 lesion involving one lobe of the thyroid, we will add a frozen section. Similarly, during surgery, my approach is when you have a patient with papillary thyroid cancer, I will do a total thyroidectomy with a central compartment clearance, prophylactic central compartment clearance. The reason is because over the years of practice, what I found is that if you don't do the central compartment dissection, the patients in their follow-up, I do stimulated TG, I don't do unstimulated TG. So in the follow-up, they have stimulated TG will be high because of the presence of small metastasis in the central compartment. And these patients keep on coming back to you with the stimulated TG, high TG, and trying to get a solution for that. Invariably, they end up with negative scans, and they end up with PET, which picks up this lymph node. So my policy has been to do total thyroidectomy and central compartment clearance. So, and in cases where you have doubt, central compartment can be sent for a frozen section, and lateral compartment neck nodes. If the preoperative ultrasound is showing suspicious node, and your preoperative FNAC has failed to demonstrate a metastasis, lateral compartment node also we do frozen section.
Okay, so it seems that you have a very good experience and you have a very good team with, where you ask for a frozen section biopsy. So
Yes.
what false positive or true negative, true positive, false? What are your sensitivity and specificity regarding a crude idea? Like in how many times like you fail, like your frozen is positive, but the final report is negative.
See, as far as papillary thyroid cancer is concerned, frozen sections are almost or always confirmatory, actually. There is no issue with frozen section. Papillary thyroid cancers, a pathologist can very well pick it up. Uh, I have not had an instance where a papillary thyroid carcinoma lymph node has been sent and it was negative and later turned out to be positive. No, it has not been there. They are very good at picking it up. But you can have issues, other issues, like for example, when in this part of the in India, we see a lot of thyroiditis. So we happen to send a few lymph nodes in the central compartment, which comes as reactive. And it has been like that because the post-operatively thyroglobulins would be low, and you can see that the radioactive scans are negative. So you can correlate that probably what the pathologist said is correct. And even in the follow-up, these patients have not come with lymph node medicine. So with that, we correlate and say that probably what they're saying in that case is correct.
Yeah. Santosh, would you like to add something on this?
Ma'am, for frozen section, as far as my practice is concerned, we usually send frozen section or follicular neoplasm only, where the preoperative FNAC is quite indeterminate. So if we are doubting the diagnosis of malignancy, only then we are going for frozen section. Otherwise, we won't take chance to get the frozen section and wait for 30 or 40 minutes to
Okay.
complete it.
So you said about follicular, though we may someday plan for a separate session for follicular thyroid cancer, but
Yes,
just a small bit.
if you have radiological diagnosis of radiologically highly suspicious nodule and the FNAC is indeterminate or it is showing follicular neoplasm, definitely we should go for frozen section. But in that scenario, also most of the time, pathologists are helpful to pathologists are helpless to differentiate between follicular neoplasm and follicular malignancy. So I think Dr. Chani will explain better how they differentiate between follicular neoplasm and follicular malignancies.
So we will certainly take this point and would like to, Chani would like to add. But this I promise, Santosh, someday we will have a dedicated session on a
Frozen
follicular
section
thyroid
and
cancer, which includes the differentiation between follicular neoplasm and follicular thyroid cancer. So Chani, would you like to add something on Santosh's comment?
In a follicular neoplasm, so the definite criteria for malignancy is capsular and vascular invasion. And for that, complete sectioning has to be done. We should section the capsule completely, then only we can rule out invasion. So in frozen, we have certain time limitation is there. we cannot do much extensive sectioning. But yeah, in certain cases, if grossly we can identify, then 60 to 70% cases we will not miss. But if patient has just a small focus of invasion, that might be missed in frozen section, because we don't have time on our side.
Yes, sir. Want to add something here?
Yeah. Actually, my practice is slightly different. If it's a preoperative follicular neoplasm FNAC, I will not go for a frozen because of the fact what Dr. Sani has said. I will not go for frozen. My issue is when you have a patient with a Thyroid 5 lesion and a Bethesda 3, where you have AUS and flush, then only we go for a FNAC, frozen. Otherwise, frozen will not be useful. In such cases, if it's a unilateral involvement, one lobe involvement, we counsel the patient. Ask them whether they want a hemi and wait for the final histopathology and go in back if it is a T2 lesion pathologically, or they want to have a prophylactic opposite side also removal during the same. So that's how we consult. We don't go for a frozen in a follicular neoplasm.
Yes,
So
sir.
also for Hurthle cell neoplasm, we don't go on for a frozen. Hurthle cell neoplasm also we don't go for.
I think it is a safe and a most practical practice, and I also follow the same, sir. And because it saves a lot of time and energy, most of the studies which quote like you do go for heavy thyroid, it is not applicable in Indian setting where every patient has to pay from their own pocket and they don't have any these insurances and all thing. And getting a surgery done itself is a very huge stress, and it is not possible for every patient to go in again and again for surgical procedures. So I think this is the best approach. Like till now, I'm not sure. Maybe when we
We can have a talk on indications of frozen also.
someday we will certainly put
Because most of the time frozen is misused.
miss.
What are the exact indications? Because frozen has its limitations.
So maybe someday
That is also very
promise to our audience कि we will keep a dedicated session on the role of frozen section biopsies in breast and endocrine surgery. Okay, and the discussion is exhaustive. Like I have many other questions related to one last question I would like to ask from Pradeep sir and also Santosh, and then we will conclude our session. This is like suppose you operate a patient, a low, intermediate, or high risk. There is no doubt, but a low or intermediate risk group. How do you decide? Do you decide as a surgeon, or you send every patient to a nuclear medicine physician to decide whether that patient requires a remnant ablation? I'm not talking about hemithyroidectomy in patient in which we have removed the thyroid completely. Do you decide as a surgeon that patient requires radioactive iodine scanning and ablation, or you routinely send all the patients following total thyroidectomy for a nuclear medicine consultation?
Okay, Dr. Sudhi, some facts are very clear. Okay, you have patients with micropapillary carcinoma. We have seen such patients having metastasis to bone. We have patients who have got extensive T4 lesions in the neck, no metastasis anywhere else in the body. Okay, you see such a wide spectrum. Okay, and to say that a patient does not have metastasis elsewhere after a thyroid surgery, what are the options you have? One is the stimulated thyroglobulin. Second one is the radioactive iodine scan. Okay, there are recommendations which say that you don't have to send the patient for a radioactive iodine scan for micropapillary thyroid cancer. Okay, their recommendations may be there. We are not giving radioactive iodine therapy. We can do a scan, a diagnostic whole body scan. So our practice here over the years, we have refined these things. Every patient who has had a thyroid cancer treatment, whether it's a histopathological surprise or a diagnosis later on, I'm not talking about those with lymph node mets. We are talking about those only who had a disease in the thyroid. Okay, they all will undergo a diagnosis. The lymph node mets invariably will undergo diagnosis, a therapeutic iodine scan. So these patients will undergo a radioactive iodine scan diagnostic along with TG, ATG. Okay, if the diagnostic scan shows an uptake in the neck, but TG, stimulated TG, is low, less than 5. I don't. If all the risk favor factors are favorable, no radioactive iodine therapy. Just the antithyroglobulin antibody should be normal. But if the patient has got a micropapillary carcinoma, stimulated thyroglobulin is more than 5, 10, 15, like that, and there is uptake in the neck, we will ablate. Why? Because I don't know whether other surgeons, but in my surgical practice, all these patients of thyroid cancer are followed up by me. I send the patient to a nuclear physician only to do the nuclear scan and therapy in if needed, and the patient comes back to me with follow-up. Okay, so these patients are under follow-up with me. So I know how many of them will have a raised thyroglobulin. Now, if they have a raised thyroglobulin, there is an issue because the patients are quite intelligent and they know that raised thyroglobulin means there is disease or at least there is functional thyroid tissue. So our protocol is very clear. All patients who have had a thyroid cancer will undergo diagnostic whole body scan based on the uptake plus considering the thyroglobulin, antithyroglobulin levels. We decide on whether therapy has to be given. Now, once the therapy has been given at 6 months, not 3 months, at 6 months, the patient will undergo another radioactive scan to prove that the uptake has gone. If the uptake has gone and the thyroglobulin has come to the normal levels within the acceptable level of stimulated thyroglobulin less than 1, then the patient will not undergo any more diagnostic whole body scan. Every year, I do a stimulated thyroglobulin test for these patients, either by withdrawal for actually 15 days withdrawal is enough. You don't have to 1 month withdrawal. 15 days withdrawal of thyroxine, check the thyroglobulin. Thyroglobulin TSH will be around 15-20, and the thyroglobulin will be less than 1, then you are happy that there is no disease. That is the protocol. But if the diagnostic scan is positive and the patient has had nodal disease, based on the disease and uptake, you may give high dose radioactive therapy and follow up similar lines.
Yes, sir. Thank you very much. And your plans are very much clear, your protocols are very much clear, and the way you have discussed it, you have shared your experience, your protocols with us, will certainly help me and the other surgeons and other participants uh, to quite a lot extent. And sir, with this, I would like to thank you all the participants, all the speakers, our moderator, guest faculties, to take out their precious time to join us today. And I hope with me, we all have learned many things about the management of papillary thyroid cancer. I have no words to explain, like, the honor that I have, and I'm extremely happy that, like, the way we discussed about it in detail, and it all enriched our the existing understanding. And with this, may I request Pradeep sir and Santosh to say few words regarding our program. This is a very small effort. We are in the process of making it, bringing it to the next level. But it is a very small effort, and we are doing it consistently. Importantly, that we are doing it consistently with interest, and we are learning quite a lot, uh, bringing new changes in our clinical practice, which is benefiting the patient definitely. So may I request you to say a few words? Our technical team, our participants will be happy to listen from you.
Dr. Sudhi, it's a tremendous effort from your side and requires a great motivation to go on like that month after month, discussing topics and spreading the right ways of, the message of how to manage these cases in the right way with the help of the specialist concerned. It's a tremendous initiative. I think you should continue it. My best wishes from my side, and in future also I'd like to contribute whenever it is needed.
So,
And
so grateful, sir. Thank you very much.
thank you, Dr. Sudeep.
Thank you. Santosh, would you like to say something to us?
Thank you, ma'am. Thank you, everyone, for the nice talk. And I think this kind of webinars are helpful for the surgical community and for all the members of the multidisciplinary team. We should continue this effort, and probably we should be more focused, like one session for iodine therapy, next session for pathologist, and next session for surgical approach. Then I think we can contribute more towards this webinar.
Thank you very much, Santosh, for your feedback. And we are always looking forward for any interested people who can actively join us and participate with us, because the basic idea of this program is to enrich our clinical practice, and evidence-based clinical practice, which once we are out from our institute, we gradually the sharpness is blunted with time because of many reasons. And through this program, we all join together to learn something new. And with this, I would like to thank you all. Friends, this meeting is recorded and will be uploaded on YouTube. Within few days, the link will be provided to you. And for those who deal with the breast surgeries, there's an information for you that in the upcoming August meet, we will be discussing about the MR mammography. So our focus will be on MR, how to read MR mammography with certain details about the basic mammography and the sonomammographies and more. So please stay connected with us. We will be sharing the details in subsequent weeks. And with this, I would like to thank you all for your active participation, for your precious time. And now, may I request you all, we all can now log out from this meeting, and with the promise that certainly we will meet again in subsequent meetings. Thank you very much.